3M Oral Care is pleased to sponsor the following educational course. Hi, my name is Joanne Jones, and I'm looking forward to presenting on xerostomia, the etiology, evaluation, and innovative strategies to treat. As a dental professional, it is our objective to not only provide effective chairside, but also self-care treatment recommendations that are supported by strong science. As a dental professional myself, I know that we see many people in our chairs each and every day that are struggling with this silent disease of xerostomia that has 24/7 discomfort. My disclosure and responsibility statement includes the following. The information is based on current scientific literature and research. The objective of the presentation is to incorporate evidence-based clinical decision-making to enhance our patient-specific treatment outcomes. And the purpose is to facilitate knowledge translation into clinical practice with the provision of resources and product. The learning outcomes for the webinar are to understand the prevalence, etiology, and impact of xerostomia on today's population, and to apply evaluative salivary assessment into clinical practice, and to effectively treat the xerostomic patient with innovative products, both chairside and with self-care. And also a focus of the webinar will be to talk about newer, innovative strategies that are backed by strong science. So the problem that exists is that xerostomia can significantly impact a patient's health and well-being. But just how prevalent is xerostomia in our population? It is difficult to know exactly what the numbers of the general population that are struggling with xerostomia because of limited data. However, the conclusive data that we do have supports that about 65% of the general population struggles with xerostomia. What we do know for certain, though, is those that have been diagnosed with Sjogren's syndrome and those that have gone through the rigors of chemotherapy and radiation for head and neck cancer are definitely struggling 100% with the effects of xerostomia. So what is the impact? If xerostomia is not effectively managed, it can significantly damage a patient's oral health and have a major impact on their general health. In fact, oral discomfort can range from mild to severe and affect every facet of life. Consider the person who is really struggling with xerostomia, that has trouble doing the simple things that we take for granted in life, like chewing their food effectively, tasting their food, swallowing. All of these things can greatly impede their social comfort and can actually lead to social isolation. Xerostomia also has a negative impact on the conditions that we treat as a dental professional, on dental caries, for instance, on plaque accumulation, on gingivitis, making them more susceptible to periodontitis, opportunistic infections like candidiasis, and other related infections, mucositis and oral lesions, all are impacted greatly by xerostomia. When we look at the etiologic pathways, there are a number of different factors that will influence the onset and the sustaining of xerostomia. Prescription and non-prescription medications are one of the strongest etiologic pathways. In fact, there are more than 1,100 xerogenic drugs when we look at both prescription and over-the-counter medications. Diseases and infections. A number of different diseases and infections, such as when we look at lymphoma and we look at head and neck infections, when we look at the absence of salivary glands, being either salivary gland agenesis or aplasia, congenital absence, nerve damage from a head or neck injury, stroke, Uncontrolled hypertension are just a number of different diseases and infections that can exacerbate xerostomia. And of course, as mentioned, Sjogren's syndrome and diabetes is another disease that will have a strong impact on the condition of xerostomia. Our medical treatments, being radiation and chemotherapy, as we will discuss a little bit further along in this webinar, have one of the most devastating and debilitating effects on the condition of xerostomia. And simply lifestyle behaviors. When we look at different social aspects, energy drinks, sports drinks, mixed with alcohol, some of these other factors that have an impact on creating a xerostomic environment. That may be transient, however, does have an impact on the etiologic pathway and also on oral health. And simply aging. Physiological factors that will support the initiation or the prolonging of salivary gland hypofunction. Let's first take a look at the effects of medications on xerostomia. This is the most prevalent cause of xerostomia. As mentioned, there are over 1,100 prescription and over-the-counter medications, with the main culprits being inhalers, antihistamines, antidepressants, anticholinergics, anorexiants, antihypertensives, antipsychotics, anti-Parkinson agents, diuretics, and sedatives, and the list goes on. Other drug classes that commonly cause xerostomia include antiemetics, anti-anxiety agents, decongestants, analgesics, antidiarrheals, bronchodilators, and skeletal muscle relaxants. When we look at xerostomia related to disease, we want to look at one of the most common autoimmune diseases, being Sjogren's syndrome. Sjogren's syndrome affects approximately 1 in 70 in our general population, predominantly, though, affecting women aged 30 to 50 years of age. What causes it? It is characterized by lymphocytic infiltration of salivary and lacrimal glands, resulting in xerostomia, dry mouth, and xerophthalmia, being dry eye. And what happens basically is the lymphocytes leave the bloodstream and they lead into the acinar glands. And in the acinar glands, this breakdown or this infiltration causes destruction, and it causes atrophy, and it causes dysfunction in the glands that support the release of moisture in these different areas. The enlargement of the major salivary glands occurs in about 1/3 of the patients with Sjogren's syndrome. Presently, there is no cure. Our goal as a dental professional and as a part of the integral healthcare network is to help our patients manage the symptoms that autoimmune diseases, in particular Sjogren's syndrome, leads to. What are some of the primary symptoms? Well, we know with the oral cavity, we know first of all dry eye, but also with the oral cavity, we are going to experience dry mouth. Burning mouth syndrome, which our patient may refer us to a symptom of the tongue feeling like it's on fire. We know that there is increased caries activity. We often, as mentioned on the previous slide, will see swollen parotid glands. And of course, oral lesions with difficulty healing because of the natural healing properties that the saliva does provide as part of our immune defense system. We also know that dysgeusia, or an altered perception of taste, is another symptom that our patient may bring to our attention. The wonderful thing about being a dental professional is we often are on the front lines of discovery, because some of these symptoms are subtle enough that your patient may not bring them to the attention of the medical professional, but they may feel more free to discuss it with us as a dental professional. Dysphagia, or difficulty swallowing is another aspect that may be brought to our attention. And then when we look at the systemic aspect of joint pain, muscle weakness, we also look at the liver, digestive problems that are mentioned on the slide here as well, are all part of the overall umbrella that is underneath Sjogren's syndrome and the effects of the disease itself. So if you suspect Sjogren's syndrome, here are 5 key questions that you can ask your patient. Number 1, do you have other dryness in your body, for example, in your skin or your eyes? Number 2, do you have overall marked fatigue? Which I know is a very general question and can be representative of other autoimmune disorders, but it is all part of the questioning of the systemic response related to Sjogren's syndrome. Number 3, do you have joint pain? Number 4, do you have any other autoimmune disease? And number 5, do autoimmune diseases run in your family? Now, there are some subtle treatment considerations that can be made if your patient is struggling with the onset of Sjogren's syndrome and maybe experiencing mild xerostomia. So hydration, of course, throughout the day. By the time your patient is actually feeling thirsty, they are already at that point of dehydration. So proactively hydrating throughout the day is of paramount importance. Chewing gum with xylitol, which we will touch on later, is such a critical recommendation, an easy one to make, and makes such a big difference in the comfort for the xerostomach, and also helping with alleviating some of the other oral symptoms. Remineralization toothpaste is critical as well, replacing essentially some of the factors that are found in natural saliva when it is in abundance. Our salivary substitutes, effective oral hygiene, and regular recare intervals. Essentially, what's going to work for this patient? What is going to keep them healthy and on track? And of course, avoidance of antihistamines, decongestants, and alcohol that also exacerbate xerostomia. Dry mouth is often a symptom of undetected diabetes as well. It can be one of the first symptoms that is going to actually clinically manifest itself. And again, as a healthcare professional, and in particular a dental professional, we have that ability to be on the front lines of discovery. So let's take a look at the snapshot of diabetes in the U.S. population presently. 30.3 million Americans, nearly 1 in 10, have diabetes. 84.1 million Americans, approximately 1 in 3, have prediabetes. And over half of newly diagnosed diabetes cases were in adults 45 to 64 years of age. New diagnosed cases of type 1 and type 2 diabetes have increased as well among our youth. But I feel one of the most critical statistics is the prediction by 2020, which is a very short time away, that 1 in 3 of our general population will have some metabolic glucose dysfunction. Those numbers are astounding. The next etiologic pathway that has a profound impact on xerostomia is cancer treatment for head and neck cancer, radiation, and chemotherapy. The salivary glands and the tear glands have a radiation tolerance of about 30 grays. Grays are the unit of measurement that radiation is measured in. When we look at that tolerance of 30 grays, it's so far away from what the typical head and neck cancer patient is subjected to. Typically, they will have 5 to 6 weeks of radiation therapy, upwards of 70 grays of radiation. They also have chemotherapy that is normally given at the beginning, during, and towards the end of the radiation therapy, which also has an impact on the xerostomach condition. The pictures on the slide here refer to the therapy as IMRT, intensity modulated radiation therapy. This consists of the fabrication of a custom-made mask with the objective of decreasing collateral damage to the accessory glands or the other salivary glands that do not need to be irradiated. The hope is to preserve function of these accessory glands so that the patient is not left with severe depletion of the salivary glands. Radiation to the salivary glands produces fibrosis. The serous portion seems to be most effective. It's much more viscous, it leads to food retention and increased plaque formation, and it becomes very, very thick, so thick that one of the greatest fears for a head and neck cancer patient that is undergoing therapy is they don't actually choke on their own saliva. It is not uncommon to see an oral cancer patient or oral pharyngeal cancer patient having to sit upright, not only for the duration of their treatment while they're sleeping, but also for many months and even years afterwards because of this fear of choking on this very thick, ropey type of saliva. Oral mucositis as well is another condition that is the end result of radiation therapy, which is absolutely devastating. If you've ever had an aphthous ulcer yourself, you know how one or two or a breakout in the oral cavity can be debilitating. Imagine having 50 or 60 of these oral lesions throughout not only the oral cavity, but the digestive tract. Chemotherapy results in xerostomia as well. However, it normally is more of a transient situation. It makes the saliva become much thicker. This temporary or transient symptom usually clears up about 2 to 8 weeks after treatment cessation. The last etiologic pathway is simply aging. When we look at the number of Americans aged 65 and older, back in 2014, there were approximately 46 million. By 2060, the estimation is that this number will actually double. So we are going to see a lot more of our patients sitting in our dental chairs that will have hyposalivation as a result of physiologic aging. How are we preparing for the needs of our population? One of the other pathways that does deserve discussion is dietary-induced xerostomia. Although it is mostly transient, it can have a major impact on oral health. Frequently combined use of alcohol and energy drinks. Alcohol being a depressant and caffeine as a stimulant is a dangerous mix. When we look at the dehydration that happens with caffeine, we look at greater consumption of alcohol to offset this. Both are diuretics and are going to complicate this increased intake of alcohol. The role played by energy drinks too is really under-researched. A lot of the research will talk about the combination of one energy drink with one alcoholic beverage, and this is not what we are unfortunately seeing in our emergency departments today amongst our youth that are having a number of energy drinks in combination with a high amount of alcohol. And the systemic complications have been noted as being very, very grave. When we look at beverage pH levels, and we're going to look at evaluation of pH a little bit further when we talk about chairside assessment. When we look at beverage pH levels and the sugar content in the chart, we can see that most pH seems to rest around 2.5 to about 3.5, which is so far away from neutral pH. So demineralization occurs when we look at any consumption of these particular products. It's going to drop that oral environment into a pH which is going to be acidic, where demineralization is surely to be occurring. So how do we battle that? How do we make recommendations that are going to counteract demineralization and put our patient into proactive remineralization? Stay tuned. Our subjective and objective analysis can be carried out in a couple of different ways. However, first let's take a look at how to recognize xerostomia. We know that there are going to be some obvious symptoms, but let's look at some of the other subtle symptoms as well. We may have our patient reporting to us dysphasia, difficulty swallowing, dysgeusia, and altered taste of perception, difficulty speaking with articulation of certain words. We might see multiple sites of cervical dentinal hypersensitivity. We also might see inadequate retention, particularly of full upper dentures. And this is often related to a dysfunction or an impairment, an impediment in the accessory glands, of which we have hundreds, probably over 1,000 of minor salivary accessory glands that help to lubricate the oral cavity so that we can have our patient experience good, adequate retention of dentures, particularly with the upper denture. We might see frothy, mucinous saliva, which would indicate that there is a lack of serous or a watery portion of the saliva, or an impairment in the flow, an inadequate flow of the saliva. We also might see increased salivary viscosity or poor mineralized calculus or no calculus on the lingual aspects of the mandibular anteriors despite the presence of plaque. When we look at it, it doesn't make sense until we recognize that this patient is struggling with low input of salivary production. We also might see glossodynia, burning mouth syndrome, burning tongue, oral mucosa that's very dry or sticky, little or no pooled saliva. In addition, we may see poor output from the labial minor salivary glands. We might see coronal and root surface caries, accelerated wear and erosion, which brings us to some clinical considerations and critical thinking as to how we're going to protect the oral environment, particularly if we see a patient that has a heavy bruxism pattern, or maybe a really aggressive toothbrusher. Maybe that recommendation from a manual toothbrush to a power toothbrush is going to be a much better recommendation for their home care. We may see parotid gland enlargement, inflammation and fissuring of the lips, ulcers of the tongue and buccal mucosa, oral candidiasis, or we might pick up on, or the patient may mention that they are experiencing halitosis. And last but not least, epithelial atrophy, where we're going to see thinning and fissuring of the oral mucosa. So when we look at this subjective analysis of salivary function, there are typical questions that may be included in the health history questionnaire as a basis for identification and assessment of dry mouth. We may use this subjective analysis, or other clinicians may want to use a visual analog scale from an objective means as well to evaluate analysis of salivary function. In that health history, there are a couple of questions that we may ask our patient. Does the amount of saliva in your mouth seem too little? Does your mouth feel dry when eating a meal? Do you have difficulty swallowing any of your food? Or are there foods that you're avoiding as well? This may sometimes be a real telltale tale. If your patient may mention to you that I don't eat, maybe certain dry foods like granola, that they have difficulty actually swallowing and they tend to feel like they're choking. Also, do you sip liquids to aid in swallowing dry food? A really good clinical evaluator is the Chalicombe scale. There are a number of different evaluative descriptors when we're looking at the oral cavity, and it is additive, which helps the clinician determine the severity of xerostomia. So there are 10 different signs here. When we look at them, the first one is the dental mirror sticks to the patient's tongue. The dental mirror sticks to the buccal mucosa. No saliva pooling in the floor of the patient's mouth. The saliva is frothy. The patient's tongue shows generalized shortened papilla. There might be an alteration in the gingival architecture. It may appear quite smooth. The patient's oral mucosa, especially the palate, appears to be glassy in appearance. The tongue is lobulated or fissured. The patient has cervical caries on more than 2 teeth, and the debris sticks to the teeth or the palate. Let's look over at the right side of the screen and look at the scoring. When we again look at the numbers here, they help us to determine the severity. So a score of 1 to 3 of these oral descriptors is going to represent relatively mild xerostomia. A score of 4 to 6 is going to be more moderate xerostomia, and a score of 7 to 10 is going to be more severe xerostomia. Very helpful tool for chairside evaluation. When we look at salivary flow rate, a normal daily production of saliva is between 0.5 to 1.5 liters, which is essentially 4 cups or more. During sleep, the flow rate is going to be almost 0. Our resting saliva is often evaluated versus the stimulation of saliva. And our submandibular glands are going to be those major contributors to the resting or unstimulated saliva, which is going to be less than 0.1 milliliters per minute. The parotid glands, on the other hand, are major contributors to stimulated saliva, which is going to be approximately less than 0.7 milliliters per minute when chewing on a wax pellet or a piece of chewing gum for 5 minutes. When we evaluate the resting or unstimulated salivary flow, there are a couple of different methods. However, one of the very easiest is to basically retract the patient's lower lip as pictured on the slide. And you're going to gently blot the mucosa. And what you should see is droplets of saliva that start to form at the orifice of the minor glands. When we look at the time taken for this to occur, it determines the resting flow rate as either being normal or being low or being a high resting flow rate. So if it takes more than 60 seconds, the patient is considered to have a low resting flow rate. If it's 30 to 60 seconds, it would be essentially represented as a normal resting flow rate. And if it's less than 30 seconds, the patient would be considered to have a high resting flow rate. Critical pH is another barometer of oral health, and it is such a critical component because that pH really determines our remineralization capabilities and demineralization capabilities. When we look at the scale pictured on the slide, we look at the enamel having a dissolution at a pH of 5.2 to 5.5. When we think back to that previous table, and most of the soda that was demonstrated on that chart was hovering around 2.5 to 3.5, we can see with normal intake of the American population of about 700 sodas per year, that there is an onslaught of the critical pH being altered on a daily basis within our general population. And then factor in that dentin dissolves at a higher pH level of 6.7. We have an issue here happening in our general population. The Stefan curve, the purpose of it is to assess or evaluate a karyogenic challenge. And what we see on the graph demonstrated here is characteristically there is a rapid drop in the plaque pH that is followed by a slower rate or a slower rise until the resting pH is attained. And that rapid drop is related to how fast the plaque microbes are actually able to metabolize the energy source, being the sugar that is provided. Now, the recovery rate, or the critical pH, first of all, is where enamel dissolution begins to occur. The recovery rate to neutrality can take 15 to 40 minutes. One of the most important factors impacting that pH recovery is salivary flow rate. If the salivary flow rate is inadequate, we are going to see this recovery taking much longer and putting that oral cavity into that situation of oral acidity for a much longer period of time, of which demineralization can definitely take over. Testing pH of saliva is so easily done chairside, and literally takes just a few moments from beginning to end. Healthy saliva should measure no lower than a pH of 6.5. In fact, we like to see it even higher than that. As mentioned, demineralization occurs below a pH of 5.5. And again, our dentin, our exposed dentin, again, can be demineralized when pH levels fall to below 6.5 to 6.7. The pH strips that are mentioned here are pH ion strips. Any type of strip used for oral assessment will suffice. Placing it into the oral cavity underneath the tongue or in the side of the cheek for about 10 to 15 seconds, measuring it, and then having your patient chew on or suck on 2 xylitol mints, which I'll talk about a little bit further, will be the determinant of how that saliva is affected by xylitol. So let's take a look at the protective factor of xylitol when we are measuring this critical pH. Streptococcus mutans and lactobacillus species are considered to be the principal indicator organisms of bacteria responsible for caries. An infant is not colonized with normal dental flora until between the ages of 6 to 30 months. And in fact, it is not unusual to see an infant having the same identical oral microflora as the primary caregiver or as the mother. When we look at some of the studies that have shown this or illustrated this, we see that the genotypes of strep mutans in infants appear identical to those present in mothers in approximately 71% of mother-infant pairs. And this acquisition occurs at an average age of approximately 2 years or 24 months. So how do we combat this? How do we combat this predominant cariogenic bacteria? Xylitol is not easily metabolized by the strep mutans. It is an energy source that basically renders the strep mutans ineffective because of this difficulty. What is xylitol? It is a 5-carbon sugar or a polyol that is both antimicrobial and antibacterial. The therapeutic dosage recommended is a minimum of 4 to 6 times a day. So how would you utilize this in your recommendation in clinical practice? If your patient is xerostomic, if they are struggling with caries activity and a number of other reasons for the diabetic, for those using a CPAP machine, anyone who's on one of the xerogenic drugs that we talked about earlier, they would use 2 mints. They would chew on them or suck on the mints for a short period of time after the consumption of any beverage or after a meal. What this does is it stimulates the salivary flow, but it also, again, provides an energy source that cannot be metabolized by the strep mutans. So the strep mutans are not going to have their level of efficacy in order to promote demineralization and enamel breakdown. Another one of the redeeming features of xylitol that is critical for so many of our patients that are diabetics is it has a very low glycemic index. It has a glycemic index of about 7, whereas when we look at some of the other products that are out there that contain sucrose or, worse still, high fructose corn syrup, we see a glycemic index of upwards of 75 right up to over 100. Also, to be really aware of as a dental professional is we want to ensure that our recommendations, that the therapeutic dosage is going to have that degree of efficacy and also be supported by the science. The over-the-counter products often combine sorbitol, mannitol, xylitol, and they don't ensure that our patient is actually getting the therapeutic dosage of 1 gram 4 to 6 times a day. So it's important to make a recommendation, such as a 3M Theramints, that is going to ensure this particular dosage. So initiating the conversation. It's such a critical conversation, not only from the impact of xerostomia on the oral cavity, but think of how you can positively impact the quality of life for your dental patient. So how do we begin the xerostomia conversation? We want to use open-ended questions. Make statements and ask questions that really get your patient to tell the story. Tell me about how you manage your dry mouth symptoms. Help me to understand how that impacts you daily. Describe for me what it feels like. What is the biggest frustration you have with your dry mouth symptoms? So we are essentially using this open-ended line of questioning, so we're not getting that yes, no response. Increasing our case acceptance and understanding is really showing empathy and having the ability to listen. Listen to the impact they feel before offering a solution. Sometimes we may wish to reiterate what they have said to make sure that we have completely understood what they're saying. Explain how the treatment will affect their life based on what they told you and how it works. Make sure they understand the full impact of refusing treatment. It is simply not enough to make a recommendation without making sure that they understand the potential outcome of untreated xerostomia. If we look at this particular chart, we can see that a decrease of oral pH, or this restricted salivary flow, is going to increase acidity. It's going to be conducive towards the formation of a pathogenic biofilm. So we have the social implication, halitosis, but we also have increased incidence of opportunistic viruses, the lack of healing of oral lesions, rampant caries, periodontal disease. All of these can be the potential outcome of untreated xerostomia. Does your patient truly understand this impact? So now the best part, the solutions and experiencing the difference. The American Dental Association suggests these basic management tips for mild xerostomia. And I really want to stress here mild xerostomia. So sipping water or sucking on ice chips. This is a proactive solution. Using lip lubricants frequently, approximately every couple of hours. Avoiding salty, spicy, sticky, sugary, or hard to chew foods. Avoiding irritants like alcohol, tobacco, and caffeine that will further lead to dehydration. Using a humidifier at night is really critical, particularly in winter months with some of the dry heating systems that we have. Chewing sugar-free gum or sucking on sugar-free mints that have xylitol in them. Again, these are basic management tips, and they're good ones, but they're for a patient that is experiencing relatively mild xerostomia. The products on the market right now, and there is a wide array of them. Over-the-counter products, there are many. And we know as a dental professional that we make these recommendations. Our patient will come back and say, you know, they worked for a period of time. However, the sustaining result was not there. It was quite temporary. But we do have a number of water-based solutions that are available to the consumer. And we have listed some of the more common ones that we will see on the product shelves in our pharmacies. Salivary substitutes, we've listed a few that are recognizable here that may be used up to 10 times a day. Often they come in a packet or a sachet that needs to be mixed with water. Sometimes this can represent an inconvenience for the patient, or the frequent use may lead to the cost being prohibitive. When we look at systemic medications, professional grade prescription are often experienced along with some devastating side effects like nausea or excessive sweating. And this can make it something that will cause the patient to not continue with the treatment because the side effects are difficult for them to endure. Then we get to some exciting news, and that is a lipid-based solution. And this is the main differentiator that exists with 3M Xerostomia Relief Spray. When we look at the product relief comparison chart here, we can see the number of products here that we may be quite familiar with compared to 3M Xerostomia Relief Spray. We can see those that are prescription required, what the delivery method is, whether they are a spray, whether they are a mouthwash, whether they are a rinse, how they are actually delivered to the oral cavity, what's the mode of action. And again, we see a standout with the 3M Xerostomia Relief Spray being lipid-based. We also see daily usage recommendations. And here you will see with the 3M Xerostomia Relief Spray that it is recommended 3 to 4 times per day, opposed to some of the other products that are up to 10 times per day. And then we look at the technology side, and we see oxidized glycerol triesters, which I will explain further as we look at the science that supports this recommendation and this new innovative product solution. Before we do this, though, as a dental professional, I want to look at our evidence-based decision-making model. It consists of patient preferences, clinical circumstances, scientific evidence, and clinical experience. But like myself, we know that somewhere in the middle and the overlap of all of these different facets is optimal decision-making that we take into consideration when we make a recommendation as a dental professional. So keeping that in mind, let's look at Xerostomia Relief Spray and what the differentiators are that exist and the competitive advantage. Again, it is the lipid-based formulation. When we look at lipid-based formulation, it is an organic compound that is insoluble in water. The technology is referred to oxidized glycerol triesters. It's designed to limit water loss, increase the substantivity because of the insolubility, which provides almost like a film that creates a barrier that will moisten and lubricate the entire oral cavity. It's rapid lasting relief up to 4 hours. What is pictured on your slide is actually a 28-day or approximately a 1-month supply. The 2 vials sometimes will require a little bit of priming to actually get the pump working. So it might take 2 or 3 primes, and the patient is instructed to spray it twice into their mouth and to move their tongue around and getting the solution onto the inflamed or irritated areas of the oral cavity. The important fact is to instruct your patient that there is a cumulative effect, and they're going to feel the full effect within approximately 3 days. And it's important to continue the use of the product. There's convenience in the delivery method. It's a spray. There is no mixing or rinsing required. The vial or the spray container is very small, can be slipped into a purse, and can be very discreetly used. It is professional grade. It requires a prescription. So what is the science? As a dental professional, this is something that we are all keenly interested in. We want to be able to make that recommendation that we have full confidence is supported by science. In 2011, there was a systematic review that was published as a Cochrane review that compared xerostomia interventions. And what they found or concluded was that there was no strong evidence that any specific topical therapy, and this included sprays, lozenges, mouth rinses, gels, oils, chewing gum, toothpaste, found that there was no strong evidence that any of them were effective for relieving the symptoms of dry mouth. Sort of discouraging to hear that as a dental professional. However, of further note and of great importance in the same Cochrane review was the observation that OGT, or oxygenated glycerol triester, salivary substitute sprays were clinically proven to have greater efficacy compared to water-based sprays. There also are a number of other articles published in professional journals that scientifically support the OGT technology. The OGT technology, which is the same technology that is in the 3M Xerostomia relief spray. The clinical study highlights, of which the references are reflected on your slide, reported that 92% of the participants in the clinical study found that Xerostomia relief spray improved their symptoms of dry mouth, so almost 100%. In a clinical study, 84% of participants reported that 3M Xerostomia relief spray had improved their quality of life. Also improved a majority of patients' ability to chew, taste, swallow, and speak in clinical studies. 87% of participants reported that the spray was easy to use. And in another clinical study, 94% of participants reported that the spray had no adverse or unpleasant side effects. Very, very compelling highlights from well-documented clinical studies, again, giving us as a dental professional the confidence to make a scientifically supported clinical recommendation. So, next steps to effectively treating xerostomia. What is our call to action? Xerostomia relief spray is available in a very easy process. It starts with the dentist providing the patient with a patient flyer. And this is important for you in clinical practice to be able to have some of the supportive and educational tools to educate your patient. Educate and also empower your patient to not only take responsibility, but also to understand why it is so important for them to treat this condition of xerostomia. The dentist sends the prescription then to transition pharmacy or TPS pharmacy by faxing, e-prescribing, or calling. The pharmacy then verifies the insurance and contacts the patient. So they do that from their end to fill the prescription. The patient then conveniently receives the prescription via mail at their front door in 3 to 5 business days. The electronic form may be downloaded from the link that is reflected on the slide. The process, once again, is very simple and straightforward. And a few handy tips to make it even simpler for your practice. Pre-fill the practice information on each form. Make copies for your operatory so they are readily available. Fill in the patient info, the quantity, and the refills. You may wish to consider refills that are patient-specific, up to 11, to have the prescription last the whole year. The doctor is then going to sign and date the form, and then the forms can simply be collected at the end of the day and send one fax in to make it a simple process for you. It can't get much easier than that. When we look at clinically managing the xerostomic patient, we need to take into consideration that there are a number of other aspects of a depleted salivary flow. And that, again, will touch on the fact of that lower pH or acidic environment. 3M Oral Care offers a comprehensive xerostomia management portfolio. Limiting water loss, lubricating and moistening the oral cavity are so important with xerostomia relief. But we also want to look at managing the risk, assessing the risk and also managing it by stimulating as much of a natural salivary flow as possible. So when we look at our xerostomic patient, we have to provide them with comfort from their xerostomia. We may be addressing sensitivity, we may be addressing caries control, and we may be helping to sustain that salivary stimulation for them. First of all, with varnishes, the statement, all fluoride varnishes being created equal, is a myth. The myth is busted. All fluoride varnishes are not created equal. A fluoride varnish should have the following properties: the ability to maintain a physical barrier for a given period of time, providing a controlled release of low fluoride levels to the tooth. That steady exposure of low levels of fluoride providing clinical benefits. When we look at this statement of all fluoride varnishes are not being created equal, I want to give a little bit more background information here. Calcium and fluoride, calcium being positively charged and fluoride being negatively charged, can combine during storage to form calcium fluoride, which renders the fluoride less effective. The differentiator in 3M's Vanish varnish is functionalized tricalcium phosphate. Functionalized TCP technology actually protects the calcium with a barrier. It protects it from interacting with the fluoride prematurely. And it's not until it actually is placed into the oral environment and broken down by saliva that it has that ability to then amalgamate or interact with the fluoride. The chemical composition is going to be much closer to hydroxyapatite, or essentially fluoroapatite, being at a higher level of effectiveness. When we look at this protective layer that keeps it separate from the fluoride in the varnish, we know that we've got this continued release that starts to happen once that saliva breaks it down. Calcium and phosphate ions continue to be released, which we'll look at in the next slide and some of the graphs. The first one here is the in vitro migration areas of Vanish varnish over 10 minutes. When we look at the number of sites over this 10-minute period, we can see that there is a high degree of migratory capability, which is really interesting because when we look at areas that are compromised, such as interproximal or around orthodontic brackets, these are areas that often fluoride does not have access to. With the migratory properties of 3M Vanish varnish, we know that that is accomplished. And being able to apply it on a surface that is only essentially toothbrush clean, it also can be applied in the presence of plaque. Very, very easy to apply with a quick horizontal brush stroke. The patient is then instructed to move the varnish around with their tongue, close their lips, move the varnish around with their tongue, and the migratory properties of the Vanish varnish are then able to essentially deliver the varnish to these compromised areas. Vanish white varnish releases even more fluoride in the acidic environment, which you can see in the second graph featured in the middle of the slide here. We can see in that lower pH or that acidic environment that we have got a greater release of fluoride. The other aspect and the differentiator here with Vanish varnish is also the fact in the last graph that the release of calcium and phosphate or phosphorus is released over a 24-hour time frame. Those are some of the differentiators that separate 3M Vanish varnish from other studies. In a clinical study, Vanish was applied to 8 anterior maxillary tooth surfaces of 19 subjects. Almost immediately after application, Vanish with TCP was noted on the teeth to which it had been applied and also on additional tooth surfaces. Within 1 hour, Vanish white varnish had migrated to more than double the number of tooth surfaces to which it had been applied. To achieve the maximum benefit from 3M fluoride Vanish varnish, it is important to communicate the following. Do not brush or floss your teeth for at least 4 hours and preferably up to 24 hours after the treatment. Instruct the patient that they may eat and drink immediately after application. However, I would instruct them to avoid hot foods, really sticky foods, hard foods, anything that might tend to disrupt the varnish. Eat soft foods during the treatment period. Do not continue hot drinks or alcohol that is found in mouth rinses during the treatment period. Also let them know that they will feel the varnish slightly on their teeth, and that will be removed completely once they are able to brush their teeth. It is so important as a clinician to again remember to apply the varnish very thin. This is the differentiator, that broad, sweeping horizontal stroke. You do not need to paint every individual tooth. Your patient will be very comfortable afterwards with just this quick horizontal stroke application. 3M Vanish Extended Contact Varnish is also another product with many diverse applications and a capability to positively impact a compromised environment. It is a site-specific, durable, protective coating, both for the enamel and the dent and tooth surfaces, and it remains on the tooth surface for up to 6 months. It's a light-cured, resin-modified glass ionomer with a 2-part liquid paste system. When fluoride is present in low sustained concentrations in the oral fluids during an acidic challenge, it's able to absorb to the surface of the apatite crystals, inhibiting demineralization. When the pH is reestablished, traces of fluoride in the solution will make it highly supersaturated with respect to fluorohydroxyapatite, which will in turn speed up the process of remineralization. Similarly, when tricalcium phosphate is used in toothpaste formulations such as ClinPro 5000, a protective barrier is created around the calcium, allowing it to coexist with the fluoride ions. During toothbrushing, the TCP comes into contact with the saliva, causing the barrier to dissolve and release calcium, phosphate, and fluoride. ClinPro 5000 with tricalcium phosphate used in conjunction with 3M Vanish Extended Contact Varnish will provide the extended contact varnish with an ability to reabsorb and also to release again continued amounts of calcium and fluoride. Win-win composition for our patients who are compromised or patients we are trying to provide that ideal oral environment. When we're looking at indications for the extended contact varnish, we can use the varnish for tooth sensitivity, exposed root surfaces, or site-specific protective coating for at-risk surfaces, such as around orthodontic brackets after the brackets have been placed, surfaces susceptible to acid erosion. Perfect solution for non-cavitated lesions are white spot lesions, partially erupted molars, which is where moisture-tolerant material is severely needed. That can sometimes be a really tricky clinical application, and this is a beautiful solution to be able to work with a partially erupted molar. If we look at the application technique for sensitivity here, basically we're going to clean, rinse, dry the area, etch it for 20 seconds, and we're done. The area does not have to be etched on a root surface. So very quick, very simple chairside procedure. Resources for your dental practice, there are a few that are listed here. As far as educational resources are concerned, there are a number of recommendations. Lexicomp has a great chairside compendium library, in particular the Drug Information Handbook, which will list those drugs that are xerogenic and will cause xerostomia, and some of the clinical considerations for your patients who are on these prescription medications. The American Dental Association has some resources as well. They have a fact sheet that may be printed off and kept in operatories to be given to your patients who are experiencing xerostomia. Sjogren's Foundation has a number of different brochures and also a newsletter that you can direct your patients' attention to that they can sign up for that will have different information about products, educational resources, general information for the patient who is struggling with the condition and also the symptoms of Sjogren's syndrome. The last message that I want to leave you with is speak up on behalf of your patients who suffer from xerostomia. I really do want to emphasize suffer. For those of us that have an adequate salivary flow, we have no idea of how the restriction of a healthy salivary flow impedes every facet of our daily life. Thank you for your time, and thank you in advance for speaking up for your patients.